Welcome to Health Tech Heroes, where we talk to innovators who are rewriting the DNA of healthcare. Today, we are welcoming Clair Canada, Executive Vice President of Payer Services at Revelo Health. With an impressive background spanning practice management, ambulatory surgical management, and PPO network operations, Clair has dedicated her career to transforming healthcare delivery and payment models. From managing high-stakes surgical centers to pioneering transparent solutions between payers and providers, Clair brings over 2 decades of frontline healthcare expertise to our conversation. Her journey from nursing administration to executive leadership exemplifies the kind of innovative thinking our healthcare system desperately needs. Welcome to Health Tech Heroes, Clair.
Thank you, Fasa. I'm excited to be here and to share my story.
This is an impressive career that you have had, and the fact that you have come all the way from the front line to the administration and the leadership role has a lot of lessons for a lot of people who have not seen one or the other or either of the sides. So Thank you very much for being here and
Sure, my pleasure.
And sharing your knowledge and wisdom. Started a career in nursing administration before transitioning into healthcare management. What personal experiences or pivotal moments inspired you to dedicate your career to transforming healthcare delivery systems?
Sure. Great. Thank you for the opportunity for allowing me to explain. So as a young girl, my father sustained a traumatic brain injury. And due to that, I spent a lot of time at the hospital with him as a young girl all the way up through the day he passed. And so with that, working in healthcare, just looking at the complexities from the patient side led me into healthcare at a very young age. I started out in a healthcare co-op, actually, in high school, and I worked for a physician there that enabled me the opportunity to continue my education, and I worked through him and kind of escalated from there. Everything from, as you just described, practice management into surgery center management and all the way into managed care. And so as I got into it through the passion with my father and showing how he had to navigate through this complex system, is that I had the opportunity to build relationships with physicians as well. And most of them being surgeons and being witness to the challenges they had in managing their business. You know, physicians go to school and they become surgeons, but they're not necessarily great at finance or managed care. Managed care started over 30 years ago, and it was new. So I just happened to pursue my opportunity in healthcare during that time when everything was indemnity. There was no such thing as PPO networks or a managed care plan. It was all indemnity. You file your claim, you get paid usual and customary. So all this experience led me to kind of grow as that grew within our industry and learn all the nuances involved with that.
This has been quite a journey, and you went back to your childhood where you had this calling, because you saw somebody who's dear to you go through the complexity, and this is where you wanted to be. And very early on in your career, you were at Baylor University Medical Center overseeing multi-specialty surgical centers. What challenges or patient stories that impacted you a lot? And you have dedicated a life for this. And what were those stories? Are there a couple of stories or one story that sticks out in your mind?
Sure. So I had a patient who, she came and saw us at a spine clinic, and she was in a lot of pain and she needed surgery. However, she wasn't ready for surgery. She had a challenging past. Her family was impacted by her condition, and it strained her marriage. And so a family friend had brought her to the office to interview with the physician, and the physician was concerned that she just wasn't of sound mind to endure surgery. And what does she do next? But she was in so much pain, she was just helpless. So I spoke to her after her appointment that day and walked her through the steps of how she really needs to kind of rebuild her life a little bit, because mentally she needed to be ready for surgery if we were going to do as such. So I walked her through how she could seek support, because now she was living on her own. She didn't work. And so I gave her some access to channels of social workers and Medicaid, and how she can get herself set up on those so she can get herself in the right position. About 6 months later, I was walking through the hospital there at Baylor, and I heard a lady call my name, and I turned around, and it was this woman. And she says, "Claire, do you remember me? My name is so-and-so." And I said, "Oh my gosh." She goes, you saved my life." She goes, I was in a lot of pain. And because of that pain, it took my family away from me, and it took my life away. But because of you, you were able to help me navigate where I could seek assistance financially and get back on my feet again. I've now had that surgery and I have my life back and I actually have my family back. So thank you. And that's why we do this. In healthcare, we're looking for that instant gratification, but the gratification doesn't always come that quickly. But in times such as that, that's what keeps us motivated to make a change.
That patient could have slipped through the cracks and gone without the help she really needed before the
Correct.
surgery.
Correct.
But even though you were working at a spine center, you made sure that she gets the help?
Correct. So I helped her navigate, went above and beyond. I mean, the surgeon doesn't feel like she wasn't a candidate for surgery due to the fact of her mental state. And so I got her beyond that and gave her the resources she needed to kind of turn her life back. And here she is today, a success story.
In her own words, saved her life. You oversaw 50 network configurations for self-funded employers. And what does it mean, essentially, for my knowledge? Yeah, and how did you navigate those complexities? What were your learnings that makes you Clair of today?
So, well, in our insurance industry, as it has evolved, so we have the fully insured space and we have the self-funded space. I'm outside Dallas. Most of our employers are self-funded, meaning that they are at risk for paying the claim. So you'll take large healthcare systems, for example. There were some clients of ours where they want to build their own PPO network for their own employees so that they could have that autonomy independent of a large health plan, like what we refer to an acronym called BUCA, Blue, United, Cigna, or Aetna. And so they wanted to control that. So it would make their premium much more affordable. So we counseled them and helped develop a PPO network for their own use, for their own employees. So we would work with the local hospitals to get contracts for that particular employer. And then through the connections that we had and applications that we supported, we were able to take those contracts and load them into our platform and reprice those claims. And after we reprice those claims, then we send them back to a third-party administrator. And their responsibility is to maintain the actual summary plan description and to actually what we call adjudicate the claim, pay the claim. So the company that I serviced for, we would reprice those and manage that network. And the byproduct of that data, we would create provider directories so the consumer knew how to pick a provider of choice that they wanted for their own plan.
Okay, this is pretty complex. You had, and how did that inform what you're doing now, Clair? Was it the understanding of the system, or it is something that drove you to say that, hey, this needs to change? What was it? What was that critical aspect of
Taking
it?
that experience with help managing PPO networks and claims repricing. So now at my current position, we took that experience and we can still reprice claims for self-funded employers. Some employers want to kind of decouple the experience today where, again, they want to be self-funded, but they want to control their own destiny. So they'll create their own network. We'll reprice those for them and share those results back to their third-party administrator for adjudication, and also provide employer analytics so they can see the cost associated with this plan. So they'll look at full billed charges for their entire population of employees, and then they'll analyze that to see, well, what are the high cost drivers? What do they say? It's always the 20% of the employees that have the greatest healthcare spend, because those patients have chronic conditions that might need to be managed a little more efficiently. So then they will employ, care coordinators, special outreach programs to help those employees navigate their healthcare. Instead of going to the emergency room for costly care, then they'll route them to a family doctor or an internist or a specialist, whatever they may need at the time of care to help manage that spend. Through that, then we also, through that same application, we look at doing data analytics for large healthcare systems. We'll take their top 5 contracts out there, and then we'll do analytics on those to see if they're getting paid in accordance to their healthcare agreement. And if they're not, then why? Is there an opportunity for recovery? Or maybe there's an opportunity for education because maybe they don't understand their contracts today between a healthcare system and a payor are not always clean cut. We call it death by 1,000 paper cuts in our industry because these contracts are most often silent, meaning that the provider doesn't understand how they're being paid. And so we review that for them and try to explain that complexity to them. Clarity out of chaos.
Yeah. And it was like a heavy learning of the system and how to navigate it. And not only that you learn and navigate, you also teach your clients how to navigate
Correct.
this.
Yes.
So you joined Revelo Health in 2020, quite recently, with the mission to level the playing field between employers and health systems and insurance companies. Just diving a little bit deeper into this, what does Revelo Health do exactly? Like, what are the exact value that Revelo Health brings?
Sure. So two things. We also own a revenue cycle management branch that will help clients who need revenue cycle management, and that's where they manage, and oversee the billing collection of receivables for large physician practices. And we also reprice claims, as I talked about a little bit earlier. So we reprice claims for self-funded employers for their own PPO networks. And then we also do data analytics for large private equity firms will purchase practices or healthcare systems, and they need assistance with taking their top managed care contracts. And we will load those into our application and reprice those claims and compare that to what we call their 837 and 835 files to see if they're getting paid appropriately or not. Again, there will be some variances, positive or negative variances, but what we try to do is empower the client to understand their contract. Again, what they think is a variance, it may not be. It may be that they think that they're expecting an outcome that is not fully there. So when you take a managed care contracts, we look at things like, we'll keep it simple. So there's the physician side. We call it the provider side, where are they getting paid according to their CPT codes that they bill or not? But carriers have multiple different types of methodologies for calculating what we call the allowable for each code. Traditionally, our healthcare system is based off of CMS, so that's Medicare, and everything's based off of an RVU, which creates what we call an RVS allowable for the provider. Most carriers now have their own proprietary methodology, which is not always understandable for our provider community. So if they understand CMS's RVU application, that's the standard in our community, but most oftentimes payers or large health plans, I use those terms interchangeably, will have their own methodology. So if one contract says, we're going to pay you 120% of CMS current year RVRVS, the payer contract may say, we're going to pay you 120% of payers RVS, but one man's RVS methodology isn't another's. They're very different. And what does that mean? So physicians don't have that transparency to know the equivalent, and we'll help them in showing them what that looks like.
May I ask you, what is the incentive for a payer or a system to have their own RVS and not follow a standardized
Great question. Because we're a repricer at our core. So in order to reprice a claim, the technology lift is significant. There's a lot of maintenance involved. So some payers, to keep up with Medicare, is huge. Medicare changes every year. There's updates to the RVU tables. So we have to update our back-end tables to support that methodology. And then you also have drugs, for example, drugs update quarterly. So again, lots and lots of maintenance. And so some payers will choose to apply their own unique methodology, because then they only have to keep with their own, and they don't have to keep up with CMS, because it is costly, it is timely, it is a lot of work. So they'll develop their own methodology that they have to maintain that's unique to them, and it makes it easier for their application to be managed.
So essentially, this helps for the payers to have their own system so that they don't have to keep updating the backend based on the CMS requirements. But then, because of that system, the pressure is now on the providers to customize each of their contracts and understand each of the payers. So there is a layer of complexity that is basically comes downstream to the providers themselves. So switching it a little bit, in your experience, what do you call as a big win for you? How have you seen this, either the end user essentially coming back and saying that, hey, Revelo Health has changed our practice for the better, and this is our experience. What would a testimonial that comes to your mind
Sure.
that you want to share with us?
Sure. So for some of our clients, one of the payers I worked with, the provider was witness to the outcome of the analytics that we did. So we showed them how their contract performed, and they wanted to renegotiate that contract. And so we would be a means of helping them through that negotiation through analytics. And so when we work with the payer would look at the entire cost spend with that provider for the whole year or that group. And I'm going to make up a figure here. Say they had $10 million in bill charges, for example. Well, when the client and I would work with the payer would say, well, we're going to offer you X in the renegotiation. But a lot of times the payer doesn't know how big that provider really is from a spend perspective, although they should. But the provider knows their practice better than the payer, right? They should. They know what their receivables are. And sometimes the carrier, when the provider would work with them, they don't understand the depth of the provider practice because they have lots of mid-levels or practitioners or ancillary services. So they don't understand how large of a dollar spend that provider represents. But then sometimes the payer, you have to show them that. You have to let them know, hey, I'm worth more than what you're saying I am. Again, if the contract's based on $10 million, but really the provider says, I'm really worth $20 million in bill charges because we're just trying to show them how big that provider is, then we will give the payer what I call a cause for pause to go back and look and go, hey, I don't think you've captured all of our physicians or tax IDs or what have you to see how big of a provider we are. And we've caught that many a time with some of the payers because payors, remember, they're also a pricer. And people aren't really familiar with that term, but they'll have multiple environments, technology environments that they're trying to keep succinct. And so, for example, if you have a large employer, then that payor can have multiple providers in different environments. So you can have a prod environment, prod 1, 2, 3, 4. But even though if you have your practitioners stored in 4 environments, again, from a technology perspective, but you have one employer, now that employer is making hops 1, 2, 3, 4, and that creates complexity, right? And so that can lead to lost data is not being synchronized, that type of thing.
All right. I won't pretend that I understood the complexity of it, but I appreciate the complexity of it. And how does Revelo, from a provider's perspective, how does Revelo help out here?
We'll look at the, if part of our tool that we use called Calibrate, we'll go out and we take their 837 files, which are claim files that the provider sends out, and we will take all of those and run those through our application to look at the total spend for that doctor in claims to work with the payer. And then in return, we'll look at, we get what we call their EOB allowable to keep it simple, explanation of benefit. A lot of people are familiar with that term, but we'll work with a remittance from the 835 to calculate that so the provider knows how they're being paid, and we'll reconcile that.
All right. Okay. So it is basically you're allowing the provider to present their best selves and show that they are big enough payers, and the $10 million, as you just a number, an example number, is a reasonable ask.
So how valuable am I as a provider, charges to that carrier. And then also, so then provider can get some clarity with the carrier to say, okay, your proprietary RBRVS rate equals X to Medicare, because Medicare is the national benchmark that everybody understands. And then, so if the carrier comes back again in renegotiation, for example, they'll again repurpose their proprietary methodology and go, okay, we're going to give you a 5% increase with their methodology. But what does that equate to in Medicare? Is that a 2% lift in Medicare or a 3% or whatever? So really, without a tool such as that, it makes it really difficult for physicians to understand. So things that I'm passionate about in our industry with that is our government really wants transparency. You hear a lot about patient transparency. What's a patient supposed to pay at the time of service, and how much is this going to cost me? And of course, as we are all consumers, we want to know transparency. However, where we lack fundamentally as a country is that providers don't have transparency into how they're being paid with the payor, because the contracts are too complex to understand. And until providers can receive transparency, consumers just can't at this time.
Sometimes we as patients go into the hospital and ask them, hey, give me a price. I want to understand this and this. And there is no way we can find clarity because they are not clear themselves.
Right. Providers will do their best to provide that, but they need to be fair.
Okay. They don't know what they are getting paid to let you know what you should be paid.
Sometimes they don't. There's a lot of complexity in there because contracts are silent in some of the reimbursement methodologies.
So as a policy, perhaps they just keep quiet, saying that, hey, we'll send the bill when we send the bill effectively.
Send you bill once we know what the payer pays. But that makes revenue cycle management hard in your patient debt. So it makes it hard.
And I would imagine AI is going to play a big role, the technology advancements that we are having right now. And how are we adapting to these changes at Revelo Health?
Gosh, AI is a big buzzword. And I just came from a conference and they talked about for every 10 times you build something in AI, 90% of it's going to fail, right? And so one of the things through transparency through our government, they mandated that hospital systems and payers publish their rates in what they call an MRF, a machine readable file. And as you can imagine, these files are huge, and there'll be various code combinations to share with the consumer how much a certain procedure costs. But then a lot of companies are out there purchasing those MRFs, machine readable files, and they're aggregating that data for sale. And so that providers or even carriers can scrape the data, scrape meaning analyze the data to see, what is the average rate for a certain procedure? But those machine readable files that are produced are most often, by the time they're published, they're outdated. So it makes it really difficult. So that's where, for me, I have clients that may purchase a tool that is derived from a machine readable file, and they're under the assumption that, well, my competitor got paid X for that rate with a particular payer, then so should I. But then by the time they get to the negotiation table, the payer can't adhere to that rate because it's out of date, and so there's a lot of misinformation out there. I think that folks are getting smarter and they're trying harder, but until the provider really receives the transparency he or she needs in that contract.
Okay. So it just, no matter how much technology you throw at it, if you don't have transparency, what are you working on? Is a barrier.
It is a barrier. So that's why I try to oversee a tool that we created that can help with some of that transparency and where the lack thereof is so therefore the provider is informed, so you can go back and ask, well, what is my rate on this? So we try to show them their areas of vulnerability so they can be empowered to make the decisions that they need to make on the provider side.
So based on your amazing experience in network operations and payer services, where do you see the future of provider relationships heading in next 5 to 10 years?
Well, there's a lot of buzz out there with employers, building their own PPO networks, or they'll go direct to a healthcare system. They will, you take a large employer and then they'll go sign a deal directly. So they're outside of a large health plan or a PPO network, and they're going to go to their own device. They're going to go straight to a large healthcare system, say Baylor. I'm going to pick Baylor. They're going to go to Baylor. They're going to do a deal with Baylor directly and bypass these large health plans. So, and therefore that means the consumer is going to have a narrow choice, right? So these employers are going to no longer purchase potentially large health plans. They're going to go narrow in option with a single healthcare system where they have a managed care agreement or contract where they'll pay X% of Medicare or what have you. That way it's transparent to the employer what he's going to have to pay, right? So, I see some of that happening for sure. Now, some of these large health plans, they're going to be around still. But employers are having to get a little more innovative in how they can control their spend, because employer spend is going up too.
And that will perhaps negatively impact private practices, wouldn't it?
Well, it could, right. If these large employers are limiting themselves to large healthcare systems, if those large healthcare systems employ physician practices, which a lot of them are, then the physicians in private practice could suffer, because then how do they get to participate in that, right? So it makes it challenging, yes.
Okay. So even though that might have a positive impact on transparency with the employers, but it might have providers itself. Like everything, there is an opportunity cost in that too.
Sure. But I will say this one thing for the private practice, because I'm very sensitive to physicians in private practice. It's where my career started, is that physicians are going to have credentials, or they're going to be, they're going to have credentials at a major hospital. So if I was that employer, and if they're going to sign a deal with a major health system, then they could look at all the physicians who are on staff at that hospital, even the private practice physicians, because those physicians are still rendering services in that hospital, and they're still valuable physicians, right? So they just need to make sure they're not leaving out the private practice, and they can incorporate that into an agreement with them too.
Yep. And if there is an organization that can help do that, I think that'll be great. And You are a leader in your field and obviously a thought leader too. What would be your advice for them to watch out for and avoid the pitfalls, and also advice for them to be successful in this area?
Always look at the source of truth. The devil is always in the details, and healthcare is very complex. So you really have to, whether you're doing a managed care negotiation or reading a managed care contract, managing a hospital, managing an OR, there's a lot of hearsay out there. And really, you have to make your decisions based on the source of truth. So you really have to be objective in your decision making and don't make any subjective decisions without verifying the source of truth every time.
Wonderful, succinct and direct advice. Go to the truth and source of truth. If there is one thing fundamentally that you can change to improve our healthcare system, what would be and why?
Sure. I think I've kind of already alluded to it earlier, is transparency between the payer and the provider. It's core. It's got to happen. Providers don't have the transparency they need in order to sustain these managed care contracts. They just really don't. And they really need that. And they should have it. And they're entitled to it. Even before managed care came in existence, as I talked about earlier, back in before it ever came out, providers were paid what they call usual and customary. Well, even back in those days, surgeons or physicians would ask me, well, Claire, what the heck is usual and customary? I said, well, it's kind of what we're in now, but now you have a contract for it. But now that contract has grown and it's complicated. And what does that mean? Back in those days, usual and customary might have been a percent of bill charge or a percent of Medicare, but really usual and customary, to keep it simple, is that carriers would buy claim data and they would look at bill charges based on a certain area to derive what is the average billable charge for that procedure. And that's how they evolve UNC, usual and customary. Managed care does the same thing a little bit, but right now managed care has evolved and it's complex with all these carriers, their own methodology and their own utilization management requirements and all that. And it's really difficult for a healthcare system and or a physician to keep up with all that. So my passion is just to help create tools to provide that transparency the best I can.
Wonderful. And before we wrap up, Claire, you will have 90 seconds. You can take 4 minutes if you want. If I missed any critical questions, or if you think that there is something really important you want to reiterate, this 90 seconds or 4 minutes is time for an open question. You select the question and the stage is yours.
Well, I think I like to say that I've learned that through my career that success is defined as learning how to be comfortable being uncomfortable. Ask the hard question. Sometimes ask a question with a question. If a practitioner or a managed care organization is asking you a question and you don't understand why, say, I appreciate the question, why you ask? Because you don't know what you don't know. So through my career, I've learned that through baptismal by fire, is that to ask the tough question, because nobody knows it all. So, but you have to be comfortable putting yourself out there, making yourself vulnerable to ask the tough question.
Yeah. And thank you very much for this, Claire. It was
You're welcome. My pleasure.
really, really encouraging to hear you be passionate about something that is a big problem, and you're saving a lot of people those death by 1,000 paper cuts.
Yeah. You want to give a payer cause for pause, because again, I call it cause for pause because you know your business, a physician, he knows his worth. He knows his business better than the payer does most oftentimes. And sometimes you just have to advocate for yourself and your worth.
And thank you for introducing these concepts.
Sure. My pleasure.
I really appreciate your time and I would have loved to hear more from you. And
Sure.
thank you
Absolutely.
again.
Well, thank you, Fossa. It's a pleasure. Thank you. Thank you for the opportunity.
It was wonderful talking to you.
All right. Thank you.